Electroencephalography is an electrophysiological monitoring method to record electrical activity of the brain. It is typically non-invasive, with the electrodes placed along the scalp, although invasive electrodes are sometimes used in specific applications. EEG measures voltage fluctuations resulting from ionic current within the neurons of the brain. In clinical contexts, EEG refers to the recording of the brain's spontaneous electrical activity over a period of time, as recorded from multiple electrodes placed on the scalp. Diagnostic applications generally focus on the spectral content of EEG, that is, the type of neural oscillations that can be observed in EEG signals. EEG is most often used to diagnose epilepsy, which causes abnormalities in EEG readings. It is also used to diagnose sleep disorders, coma, encephalopathies, and brain death. EEG used to be a first-line method of diagnosis for tumors, stroke and other focal brain disorders, but this use has decreased with the advent of high-resolution anatomical imaging techniques such as magnetic resonance imaging and computed tomography. Despite limited spatial resolution, EEG continues to be a valuable tool for research and diagnosis, especially when millisecond range temporal resolution is required. Derivatives of the EEG technique include evoked potentials, which involves averaging the EEG activity time locked to the presentation of a stimulus of some sort. Event-related potentials refer to averaged EEG responses that are time-locked to more complex processing of stimuli. This technique is used in cognitive science, cognitive psychology, and psychophysiological research. Medical use. A routine clinical EEG recording typically lasts 20 to 30 minutes and usually involves recording from scalp electrodes. Routine EEG is typically used in the following clinical circumstances: to distinguish epileptic seizures from other types of spells, such as psychogenic non-epileptic seizures, syncope, subcortical movement disorders and migraine variants; to differentiate organic encephalopathy or delirium from primary psychiatric syndromes such as catatonia; to serve as an adjunct test of brain death; to prognosticate, in certain instances, in patients with coma; to determine whether to wean anti-epileptic medications. At times, a routine EEG is not sufficient, particularly when it is necessary to record a patient while he/she is having a seizure. In this case, the patient may be admitted to the hospital for days or even weeks, while EEG is constantly being recorded. A recording of an actual seizure can give significantly better information about whether or not a spell is an epileptic seizure and the focus in the brain from which the seizure activity emanates. Epilepsy monitoring is typically done to distinguish epileptic seizures from other types of spells, such as psychogenic non-epileptic seizures, syncope, subcortical movement disorders and migraine variants; to characterize seizures for the purposes of treatment; to localize the region of brain from which a seizure originates for workup of possible seizure surgery. Additionally, EEG may be used to monitor certain procedures, to monitor the depth of anesthesia, as an indirect indicator of cerebral perfusion in carotid endarterectomy, to monitor amobarbital effects during the WADA test. EEG can also be used in intensive care units for brain function monitoring, to monitor for non-convulsive seizures, non-convulsive status epilepticus, to monitor the effect of sedative anesthesia in patients in medically induced coma, to monitor for secondary brain damage in conditions such as subarachnoid hemorrhage. If a patient with epilepsy is being considered for resective surgery, it is often necessary to localize the focus of the epileptic brain activity with a resolution greater than what is provided by scalp EEG. This is because the cerebrospinal fluid, skull and scalp smear the electrical potentials recorded by scalp EEG. In these cases, neurosurgeons typically implant strips and grids of electrodes under the dura mater, through either a craniotomy or a burr hole. The recording of these signals is referred to as electrocorticography, subdural EEG or intracranial EEG, all terms for the same thing. The signal recorded from ECOG is on a different scale of activity than the brain activity recorded from scalp EEG. Low voltage, high frequency components that cannot be seen easily in scalp EEG can be seen clearly in ECOG. Further, smaller electrodes allow even lower voltage, faster components of brain activity to be seen. Some clinical sites record from penetrating microelectrodes. EEG may be done in all pediatric patients presenting with first onset of febrile or complex febrile seizures. EEG is not indicated for diagnosing headache. Recurring headache is a common pain problem, and this procedure is sometimes used in a search for a diagnosis, but it has no advantage over routine clinical evaluation. Research use EEG, and the related study of EPS are used extensively in neuroscience, cognitive science, cognitive psychology, neurolinguistics and psychophysiological research. Many EEG techniques used in research are not standardized sufficiently for clinical use. Advantages: several other methods to study brain function exist, including functional magnetic resonance imaging, positron emission tomography, magnetoencephalography, nuclear magnetic resonance spectroscopy, electrocorticography, single photon emission computed tomography, near-infrared spectroscopy, and event-related optical signal. Despite the relatively poor spatial sensitivity of EEG, it possesses multiple advantages over some of these techniques. Hardware costs are significantly lower than those of most other techniques. EEG prevents limited availability of technologists to provide immediate care in high-traffic hospitals. EEG sensors can be used in more places than fMRI, SPECT, PET misses, or MEG, as these techniques require bulky and immobile equipment. For example, MEG requires equipment consisting of liquid helium-cooled detectors that can be used only in magnetically shielded rooms, altogether costing upwards of several $1 million, and fMRI requires the use of a 1-ton magnet in, again, a shielded room. EEG has very high temporal resolution, on the order of milliseconds rather than seconds. EEG is commonly recorded at sampling rates between 250 and 2000 Hz in clinical and research settings. But modern EEG data collection systems are capable of recording at sampling rates above 20,000 Hz if desired. MEG and EROS are the only other non-invasive cognitive neuroscience techniques that acquire data at this level of temporal resolution. EEG is relatively tolerant of subject movement, unlike most other neuroimaging techniques. There even exist methods for minimizing, and even eliminating movement artifacts in EEG data. EEG is silent, which allows for better study of the responses to auditory stimuli. EEG does not aggravate claustrophobia, unlike fMRI, PET misses, SPECT, and sometimes MEG. EEG does not involve exposure to high-intensity magnetic fields, as in some of the other techniques, especially MRI and misses. These can cause a variety of undesirable issues with the data, and also prohibit use of these techniques with participants that have metal implants in their body, such as metal-containing pacemakers. EEG does not involve exposure to radioligands, unlike positron emission tomography. ERP studies can be conducted with relatively simple paradigms, compared with IE block design fMRI studies. Extremely uninvasive, unlike electrocorticography, which actually requires electrodes to be placed on the surface of the brain. EEG also has some characteristics that compare favorably with behavioral testing. EEG can detect covert processing. EEG can be used in subjects who are incapable of making a motor response. Some ERP components can be detected even when the subject is not attending to the stimuli. Unlike other means of studying reaction time, ERPs can elucidate stages of processing. EEG is a powerful tool for tracking brain changes during different phases of life. EEG sleep analysis can indicate significant aspects of the timing of brain development, including evaluating adolescent brain maturation. Brain activity can also be monitored by Cort-S. In EEG, there is a better understanding of what signal is measured as compared to other research techniques, i.e., the bold response in MRI. Disadvantage is low spatial resolution on the scalp. fMRI, for example, can directly display areas of the brain that are active, while EEG requires intense interpretation just to hypothesize what areas are activated by a particular response. EEG poorly measures neural activity that occurs below the upper layers of the brain. Unlike PET and MRIs, cannot identify specific locations in the brain at which various neurotransmitters, drugs, etc. can be found. Often takes a long time to connect a subject to EEG, as it requires precise placement of dozens of electrodes around the head and the use of various gels, saline solutions, and/or paste to keep them in place, while the length of time differs dependent on the specific EEG device used. As a general rule, it takes considerably less time to prepare a subject for MEG, fMRI, MRIs, and SPECT. Signal-to-noise ratio is poor, so sophisticated data analysis and relatively large numbers of subjects are needed to extract useful information from EEG. With other neuroimaging techniques, simultaneous EEG recordings and fMRI scans have been obtained successfully. Though successful simultaneous recording requires that several technical difficulties be overcome, such as the presence of ballistocardiographic artifact, MRI pulse artifact, and the induction of electrical currents in EEG wires that move within the strong magnetic fields of the MRI. While challenging, these have been successfully overcome in a number of studies. MRIs produce detailed images created by generating strong magnetic fields that may induce potentially harmful displacement force and torque. These fields produce potentially harmful radio frequency heating and create image artifacts, rendering images useless. Due to these potential risks, only certain medical devices can be used in a MR environment. Similarly, simultaneous recordings with MEG and EEG have also been conducted, which has several advantages over using either technique alone. EEG requires accurate information about certain aspects of the skull that can only be estimated, such as skull radius and conductivities of various skull locations. MEG does not have this issue, and a simultaneous analysis allows this to be corrected for. MEG and EEG both detect activity below the surface of the cortex very poorly, and like EEG, the level of error increases with the depth below the surface of the cortex one attempts to examine. However, the errors are very different between the techniques, and combining them thus allows for correction of some of this noise. MEG has access to virtually no sources of brain activity below a few centimeters under the cortex. EEG, on the other hand, can receive signals from greater depth, albeit with a high degree of noise. Combining the two makes it easier to determine what in the EEG signal comes from the surface, and what comes from deeper in the brain, thus allowing for analysis of deeper brain signals than either EEG or MEG on its own. EEG has also been combined with positron emission tomography. This provides the advantage of allowing researchers to see what EEG signals are associated with different drug actions in the brain. Mechanisms. The brain's electrical charge is maintained by billions of neurons. Neurons are electrically charged by membrane transport proteins that pump ions across their membranes. Neurons are constantly exchanging ions with the extracellular milieu, for example to maintain resting potential and to propagate action potentials. Ions of similar charge repel each other, and when many ions are pushed out of many neurons at the same time, they can push their neighbors, who push their neighbors, and so on, in a wave. This process is known as volume conduction. When the wave of ions reaches the electrodes on the scalp, they can push or pull electrons on the metal in the electrodes. Since metal conducts the push and pull of electrons easily, The difference in push or pull voltages between any two electrodes can be measured by a voltmeter. Recording these voltages over time gives us the EEG. The electric potential generated by an individual neuron is far too small to be picked up by EEG or MEG. EEG activity therefore always reflects the summation of the synchronous activity of thousands or millions of neurons that have similar spatial orientation. If the cells do not have similar spatial orientation, their ions do not line up and create waves to be detected. Pyramidal neurons of the cortex are thought to produce the most EEG signal because they are well aligned and fire together. Because voltage fields fall off with the square of distance, activity from deep sources is more difficult to detect than currents near the skull. Scalp EEG activity shows oscillations at a variety of frequencies. Several of these oscillations have characteristic frequency ranges, spatial distributions, and are associated with different states of brain functioning. These oscillations represent synchronized activity over a network of neurons. The neuronal networks underlying some of these oscillations are understood, while many others are not. Research that measures both EEG and neuron spiking finds the relationship between the two is complex, with a combination of EEG power in the gamma band and phase in the delta band relating most strongly to neuron spike activity.